What I'm going to review with you is a way to answer the debate you were just listening to, because that was a debate that was informed of eminence, but not evidence. And this is about evidence. So what we're going to look at is what surgical outcomes in spine surgery conducted across the state since 2011. We're going to go over outcomes as they're reported by the patient, PROs. We're going to take these outcomes and we're going to compare them through administrative database contrast with CHARS data to look at cost and show how participation in this type of registry actually lowers costs across the state. And then lastly, I'm going to show you some of the research that is based on this robust data set that folks in this audience participate in to write papers about this. And I'll also show you some predictive tools that, based on the 25,000 patients that we have in the spine surgery registry, I use a tool on a daily basis for my patients where they sit down and they plug in their age, their sex, who their insurer is. My MA helps them with their diagnosis, but they put in their own comorbidities and risk behaviors. Do you smoke? Do you take steroids? Do you have asthma? And then their own pain scores, and they do their disability index. They see their score, and they hit calculate. And this tool tells you the odds that you're going to have surgical success in the first 3 months as you, being a patient, define success, not as me being a surgeon define success. And if you alter your behaviors, you watch the calculation dramatically change. And a conversation around shared decision making is so much easier when the patient is making the decisions and sees the immediate change in the likelihood of their success. And I'll show you that as a predictive tool. So this is us. We started in 2011. It was a pilot then, 1,000 cases, just to do an audit of the data to make sure that we were asking the right question and the abstractors were able to answer it accurately. And then from there, it rolled out. It's a registry based on fusion, so you see fusion as a predominant procedure, and that's because the controversy is around fusion. The hospitals are growing. We're now outside the state of Washington and growing in California, and the UC Irvine is on board, and some of the other UC systems are active in conversation around joining. These are slides about, so the first one is about physicians and hospitals. The second set of slides is about patient behaviors and characteristics. So when you're looking at registry enrollment, as you all are in the midst of now doing, you can have data that looks like this. This data isn't much good. It just tells you which hospital has which smoking rate. The data that's more important is when you break it down into cohorts, where you can find out the difference in behaviors at each of your respective hospitals within the system, or difference in behaviors in respective hospitals across a population or a region. And there are differences, and they show up in the cohort analysis, so you want to know that. From a public health perspective, you can talk to your payers, your purchasers, your Boeings, your Microsofts, and you can show what public health impact you have. This is the decline in smoking in patients headed for surgery that are enrolled in the SCOAP program. And you see over time, that dramatically drops. These are the individual hospitals. So if you're looking at participating in registry functions, you want to be able to get this kind of cohort analysis on each of your individual hospitals. Those are individual hospitals. And as you can see, everybody's doing pretty good except them. Those folks are having a difficulty with an increased rate of smoking over a sustained period of time. And all of us who are surgeons know this is detrimental to the outcome of the procedure. So the nice thing about a registry that has this kind of analytic capability is you can identify folks who need additional help, and you can highlight for them how to get that done. This is opioid use. Again, as what we would call a signal metric, you can see that, geez, half of the folks we operate on are taking opioids. And in that population, there are some folks, a subpopulation, who are addicted. And as Dave mentioned, that confounding behavior is significantly destructive to your outcome. So it is important to be able to do cohort analysis to find out where are the bad folks. And one of the things you'll notice in looking at these slides, I've got to show it here, I don't need to see it, is the longer you're in SCOAP, the more you learn, the better you do, the more cost savings. You'll see that in other slides. Watch the blue line. Longer you're in, the more you learn, the better you do. And a registry should provide that for you. It should help you with actionable change that makes care of your patients improve. So this is a slide on diabetes management. What you'll see is there are some hospitals, and pay attention to 26. There are some hospitals, and we change the number every quarter, so there's no way to track which hospital that is. It'll always remain anonymous, but we know who it is, but no one else can. But the hospital 26, who knows who they are, they're having a bit of a struggle in just getting a blood sugar on a diabetic. Now, if you're a surgeon and you're operating on diabetics, you want to have that blood sugar under control. Now, watch what happens. So again, the longer you're in the registry, the more you learn, the better you get. Now, watch what happens if the patient in number 26 goes to the operating room and is hyperglycemic. 4 out of 5 times, they do not get insulin. So this comes right off the MAR. It's coming right out of the medical record. You know whether they got insulin for that hyperglycemia or not. Now, as a surgeon operating in that hospital, you'd be a little worried. As a patient in a community serviced by that hospital, you'd be a little worried that you're going to go in with diabetes, a known condition, you're going to go through the operating room, the perioperative control of your blood sugar will not happen. And so the subsequent complications at this hospital are going to be manageable and dramatically improved by simple nursing protocols, because there are other hospitals that do a doggone good job with this. So they have figured that out, and that is the benefit of a registry. Those who have figured it out can help those who are still learning to figure it out. So again, the longer you're in, the better you get, the more you learn, the better your outcomes. Postoperative complications. For administrative folks, this is what's called a never event. And what never means is you're never going to get paid for that event. So it's hugely impactful on your bottom line. And again, the longer you're in, the more you learn, and the less frequent that problem occurs, the greater your cost savings. The less your ICU, inadvertent ICU admissions, the less surgical site infections, the less new neurologic deficits postoperatively. So here's serious adverse events, and that's exactly what I was just talking about. New neurologic deficits, back to the operating room for revision, ICU admission, and the longer you're in, the more likely you are not to have these difficulties, the better the solvency of your system and of your hospital. These are composite events, so this is everything including urinary tract infection or DVT or slip and fall out of bed. Surgical site infection, this is one of the benefits of a registry, is you can instigate what's called a exploratory metric. That means somebody on your metrics committee, of which there are members of surgeons in this audience who participate in that metrics committee, come up with an idea that we can alter surgical infection rates by putting antibiotics in the wound. So the registry develops a simple yes-no answer. That's called a signal metric or an exploratory metric. At the end of the operation, does the surgeon dictate that antibiotic powder was put in the wound at the time of closure, yes or no? And what you find in SpineScope is the numbers on that now exceed 17,000. And when they reach 32,000, we'll have sufficient power to answer that question. And all the journal articles that you've been reading up to this time are grossly underpowered and don't know what they're talking about. It takes those kinds of numbers to get an answer which is valid. The confounding factors eliminate the validity in anything less than that number. And you can reach that number using the registry. These are the different hospitals and their infection rates. This is not risk adjusted, so these particular hospitals should not be concerned about this data, other than it is something to be paying attention to. But until these data are risk adjusted, when some of these hospitals will climb and some of these hospitals will decline. But it's important to know that some of our hospitals have more difficult populations to deal with, and it shows up in their numbers. This is just an example of what you can use as a health system by employing this kind of data. These are simple questions, and they're not really inflammatory. It's just length of stay for a surgical procedure, length of stay for a lumbar procedure, and did you do the proper x-rays? You can take very detailed questions, and across a system or across the registry, you can compare different hospitals for their performance and find out who's doing a very good job, who has room for improvement, and how the good folks who are doing a good job accomplished that, and then spread that news across so that the population as a whole does better and has fewer complications. So this is something I use in my office every day. I give my patients this tool which predicts their outcomes based on their characteristics. So what we see here is the age of the individual is 90, and we've got him as a private insurer, and we have him as currently smoking, it looks like. Can you change that to make him a non-smoker? That's the third category. Up, 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 up. Yep, go down. Yep, there it is. Make him a non-smoker, and then give him stenosis. Yeah, okay. So it's a virgin case, first time. Make his pain score 8 for his back, 9 for his leg. That's his back. There's his leg. Scroll down. I've already pre-populated the ODI, so we don't have to go through that. Hit the predict outcomes button, and boom. He has a 80% likelihood in the first month that he'll have a significant change, either have no pain or minimal pain from his surgery, and at the end of a year, he has an 80% likelihood that he will have minimal or no pain. And the change in his pain, remember, a minimally significant clinical difference is 2 NRS points, and he went from an 8 to a 3, 2.5. So he had a 6-point drop. So he had a 3-fold greater than clinical significant change in his pain. So his success is dramatically likely. Now let's flip this back. If you could go back to the calculator, make him 45 years old. And let's put a classic patient in here. So he's 45 years old. He's on LNI. Oh, well, maybe we won't be able to. Well, so let me talk you through this. He's 45 years old. He's on LNI. He's smoking. Yeah, so 45. Insurance will be labor and industries, any of the public insurance, labor and industries, Medicaid, any of those. Give him prior surgery, radiculopathy. So next one up is prior surgery. Let's have him smoke. Let's have him take some steroids. That'll be on the right-hand side. And I think, do we have him smoking up there? Yeah. And then keep his pain score and everything else the same. And hit the calculation button. Everything else is the same. And he has a 20%, 1 out of 5, likelihood that this is going to work. And I have my patients do this themselves. And I ask them, okay, change your behavior. Get off the narcotics, get off the cigarettes. And it recalculates, and they realize that, geez, if I do this stuff myself, my surgeon has a high likelihood of improving me, and I have a higher likelihood of having a beneficial outcome. So this works for functional metrics. That's what this one is. This is an ODI metric. I can do it for pain score metrics. There are all the predictive tools you can use all work on the same base. All of them are based on 25,000 cases. So they have significant power. They have significant predictive capability. Numeric rated pain scale. It's what others call VAS, visual analog scale. You can't do VAS with electronic entry remote abstraction. So what you do is an NRS, and they have been correlated to each other and are identical and are significant and are valid measures of the same thing. So a numeric rating pain scale is the same digitally as a visual analog scale is visibly. But you can't enter VAS when you abstract. In looking at this, institutions like this and health systems like this are motivated to look at registry work, either internally or externally. And I want to compare and contrast here. If you look at what happens in SCOAP, you are participating broadly across the community. You are, like an institution such as this, perceived as best in class, as you should be. And you're seen by others in the community and the state in general as representing what the best in healthcare should be. Versus a homegrown system that is internal will be seen as a system that only looks at its own outcomes and isn't as concerned for the outcome of others of the community in general. The data entry issue for homegrown systems is dramatically different than SCOAP. And one of the key lessons, one of the cardinal features of a successful registry is that doctors do not touch the data. No data entry is done by doctors. Doctors define conditions, they establish metrics, and they analyze the data when it's gathered, and they do not touch it during the gathering. So if you look at the grandfather of registry work, Peter Fritzel, it is one of his sine qua nons. It's a key axiom of success. If you ask our neighbors to the north, why did the Canadian system fail? Their docs put in the data. And when docs put in data, you get inconsistencies, you get gaps in the data, and you get loss of validity of your data. So ours is 99% abstracted. Docs don't touch it. Yeah, Rod?
But Neal, I would even argue, I think it's worse having institutions fail because it's just as bad having, in our experience, in the end, you can come up with it. But when we were involved in these multi-center trials, there's some inherent value in having, let's say, an independent
third party, separate entity.
Who's going to believe your research paper if you're collecting your own data?
And I use the analogy of Michael Jordan. Michael Jordan playing basketball in a scrimmage with his own team, he plays wonderful basketball, but it doesn't matter. The only thing that matters is when that team that he is on participates in the NBA Finals in front of everybody else competing against the very best other folks. And the same thing happens here. If your registry system is external to you and you're at the top of the class, it is different than if you have a system that is homegrown, that is internal, that's insular, that is perceived as we are just looking at ourselves. Because you can't have the same degree of gravitas with the homegrown one. And then these other components are what we've been fortunate with. As I say, many of the surgeons in this room participate in this, and there is exceptional research capability. There are the most advanced metrics that are validated are in SCOAP, and it is well funded based on the robust data that we have. And then lastly, in our state, the BRE, which is a collaborative that gives recommendations to the governor, has universally and unanimously recommended that all spine surgery that's done in the state be tracked in a methodology such as SpineScope. I know everybody's got to get to work, so I wanted to close this off with a recommendation that for many of us, we want to be sensitive to the notion that all of us are vulnerable to self-regard, but those of us who participate in leadership positions would want to have a system like yours and a hospital like yours lead from the front, which is really where an institution like this belongs. Any questions? Thank you so much for letting me have part of your morning.